Welcome back to the Dr. Greg Jones Optimization Academy podcast. Hey, y'all, check this out. Our genes are not our destiny, but they do hold the potential to our health potential. While most of us inherit a fixed DNA sequence, how these genes are expressed can dramatically shape the trajectory of our lives. And today we're talking about the science that empowers us to influence that expression through lifestyle, environment, and precision medicine. In today's episode, I am joined by a truly exceptional guest, Dr. Laura Lile. She's one of the few professionals in the country who is both board certified as a medical physician and a registered pharmacist. Her unique dual training gives her a 360-degree view of healthcare, from the molecular mechanisms of medications to the art of personalized proactive treatment. Dr. Lile is also a true innovator. At just 25, she opened one of the first drive-through pharmacies in the Midwest, complete with a cappuccino machine, and later pioneered concierge telemedicine long before it became the norm. But today, her focus is firmly on the future: longevity, genomics, and data-driven medicine that doesn't just manage disease, but helps prevent it altogether. In today's episode, we're going to explore how genomics and epigenetics intersect, how tools like the IntellxDNA are helping practitioners turn complex genetic data into personalized treatment plans, and why your SNPs, those tiny variations in your DNA, might hold the key to unlocking better brain health, metabolism, cardiovascular resilience, and more. If you've ever wondered how your DNA can inform, not dictate your future, and how a personalized approach can radically change the way we think about prevention, you're in the right place. Let's dive in. All right, Dr. Lile, welcome to the show.
Thank you, Greg. I'm super excited to be here.
And we are.
Yeah, it's very snazzy.
Yeah, snazzy is my thing. Snazzy is my thing. I'm all about it. You've seen me at conferences. I'm all about the snazz. I feel like if you have enough snazz and pizzazz, you get some mistakes. You get a few mistakes. You mispronounce a couple things if you're in a good suit. But you gotta pick it up. And we are recording the day after Mother's Day, so I want to say Happy Mother's Day to you.
Thank you so much. It's beautiful when you have your kids grown, and now I'm going to be a grandparent. It's hard to believe. My daughter, I'm having my first grandchild, and so Mother's Day took a whole new meaning this year, right?
It does. It does. Now you get to be double.
Congratulate my dog.
In a few years, double the gifts. I want something from you and the grandkids. I want everything. I want everyone, shower me with gifts as the matriarch of the family. So you have an amazing background, a very unique background, being both a pharmacist and a medical doctor. Before we get into how that shapes your approach, how does that happen? Because most people, when they finish one graduate program, it's tapped out. We're done. You went back for more. How'd that happen?
Well, with two small children, and third one during medical school. I'm not sure I would recommend that to young women attending medical school, but mine was really, my family jokes it was postpartum depression. After I had my daughter, who's pregnant right now, my 31-year-old, I literally woke up one day and realized I had to go back. Remember, I had been out 12 years filling prescriptions as a pharmacist and owning my own independent pharmacy. And every day that went by, I would fill prescriptions. And then they would hand me more, and I would say, well, this prescription, if they wouldn't have taken this, it wouldn't have required this, and in the end, would they have been better off if they would have been on nothing? And so I think as a pharmacist, I started seeing these patterns that, I think I could do this and do it well. And I woke up and decided the only way I can really effectively help patients is to go back and get a better understanding of why doctors prescribe so much. That may sound like a crazy reason, but I also felt like I always joke, I wanted to be a better pharmacist. So I kind of identify still as a pharmacist because 38 years later, I'm still practicing as a pharmacist.
All right.
And
so
PharmD.
That's pretty awesome. Would you say is it are you doing like 80% medical, 20% pharmacy? Is it kind of vary?
That's a perfect split, 80-20. Yeah.
Okay.
I still answer pharmacy questions every day. We have a compounding lab in Michigan and we have a whole team there. So I kind of oversee and, just when they have questions that they need answers to. But also I've always been the chef in the kitchen, right? So I know how to whip up things when my patients need it or problem solve. And so I don't know any other way to practice medicine, Greg. I literally, when I think of something, I'm like, oh, this would work really good when this is combined. Let's just make that. So,
awesome.
If I didn't have the compounding pharmacy, I think it would be harder for me because I
Oh,
like to
yeah.
continue having that creativity.
And that allows you to have it. That's pretty awesome. That is incredible. So, how is it? We're going to dive into a lot of the stuff here, but having that dual training, how did that change your approach to medicine, like overall? Like knowing now both sides, detailed on both sides of the fence versus that one.
Well, first of all, as a pharmacist, we're really looking at the why behind the pathways, the chemistry, right? Most people don't want to be a pharmacist because it's a lot of organic chemistry and science. But we dig into the why behind things. So genomics and pharmaceutics, and we think of things more at the cellular level. And so when I practice as a pharmacist, I originally, before becoming an MD, I was really good at understanding all the chemical pathways and at the cellular level. When I went back to be an MD, first of all, what an advantage. I was bilingual going into that medical school because, I could speak the language of pharmacy. And so I was able to really focus on diagnostic skills. And because once I could get that down, I knew what to do for a treatment. It was much easier. And so when you take both of them together, it really guided. I've always think of myself working in cellular health because I've always been having a desire to get to root cause medicine. And I think even at a time when that wasn't very popular gosh, 20 years ago.
Okay,
So,
awesome.
yeah.
That's incredible. And it's good to have both. Great to have both. I understand. And I think it gives you empathy for both too. Because sometimes, honestly, as a doctor, especially with the commercial pharmacy, the empathy meter can be turned up a little bit sometimes. And I'm guilty of it too. I'm just like, what's taking so long? What is this PA? What are you waiting on? What do you mean? This is the best. This is the best. And I hope they don't do this anymore. So sometimes this is the only thing that would piss me off about the commercial pharmacy. Like you send a script in,
Mhm.
let's just say they don't have the medication. It could be back ordered. Maybe they're waiting on it, right? Sometimes, and I don't know if the patient just didn't get the translation, but they would be like, "Oh, the pharmacy doesn't have my prescription." They call the office mad at me.
Every day. I'm being serious. I'm not joking about this. We'll get an email or a text to our office saying they've tried to contact you 3 times. I'm like, really?
Oh, that's the best too.
Keep phone log.
Yeah,
We
no.
know what phone calls are coming in. I think it's just a universal statement that's made.
I know. We ain't got your prescription and we sent it to your doctor's office. You need to contact them. Don't bother me. I got I got 400 scripts to fill. Don't bother me. Go bother him or her. They got
It's
time.
600 with all the consolidation of
Oh my
pharmacies.
God,
And
I
even get
know.
more
It's like,
so. Yeah.
it is a lot. It is a lot. So, speaking of pharmacies, you were quite the innovator. So, you opened a drive-through pharmacy at, is this right? 25 years old?
Yeah, I was 25 years old.
That is amazing. At 25, I was going through drive-through like fast food spots.
Like McDonald's.
That was it.
Drive-throughs that inspired me, but,
Yeah.
I had my son, was very young, like 6 months old, and, I was in a cold climate, and I must I look at things really differently. I practiced as a traditional pharmacist for only 1 year. I came out and, managing the equivalent of a CVS type pharmacy, but it was great. I learned how to manage people at 24 and how to turn inventory. And I realized that I wasn't going to be able to do all the things I wanted to do. And I had my moment. Should I go back to medical school or should I open a pharmacy? And I never knew I was going to do both. Right. But when I made that decision to open the pharmacy, it was in a small town in Ohio, Bellevue, Ohio. I had this idea that, gosh, there was an abandoned building, like a Wendy's. It was an older style building. And I thought, wow, how many times have I carried my son in his car seat, through the pharmacy after I've called it in myself from the doctor's office, to pick it up. And it was such a hassle. I thought, why don't we just have a drive-through pharmacy? And it was very radical, I have to say. There was none in the Midwest, and I had to fight pretty aggressively to get it. I don't know what gave me that strong desire at such a young age, but I feel like I've been pretty good at following my intuition, and it just made sense to me. And I'll tell you, all my competitors within a short period of time had drive-throughs.
Everyone's got a drive-through now. They
Yeah,
all do. They
yeah,
all do. They can't, all
yeah,
the Walgreens, all the CVS, and they can say, and they did thank you for it. You should get like
yeah.
some type
You're
of
right.
residuals on that. Like every time you fill a script, you need
Yeah,
something for that,
that would
right?
be nice. Yeah.
So another really cool thing you got into, this is, I believe, looking at my notes here, 2006 was concierge medicine and telemedicine
Mhm.
before that was a thing.
Yep.
How did that happen?
Well, I practiced as a traditional medical doctor. I'd come out of medical
Right.
school. I've never worked for anyone else except 1 year, except myself, right? So I'd already gone to medical school and had experience on how to run an office. It just made sense. I came out in private practice and did that for 5 years. And during that time, I could see the writing on the wall, even all those years ago. I have run businesses, I understand cash flow, and I could see that, the reimbursements were going down, the length of time it took to get your money when you're still making payroll. And I just knew that I had not forfeited 7 years of my life with small children, to not have time with my patient. And I really prayed and deliberated. And I came up with this idea because my family are all lawyers and they bill by the hour. And I thought, why couldn't I have all these patients? Remember, when I opened my practice, Suzanne Summers had written her book, shortly around that time on the sexy years. And I was the only compounding pharmacist MD in the US. So, I mean, I was bombarded with patients. And I realized this isn't the way I want to practice medicine. I want time with my patients. And I had a philosophy that build it and they will come. And, I literally opted out of all the insurance and built on an island of all places in Michigan, Groseal, Michigan. This is an island of 10,000. Think about that. I mean, right? I mean, who moves to an island and says, I'm not taking insurance anymore? And
Mm-hmm.
I think I'm a platform that says concierge medicine can work. I didn't call it concierge back then. I called it pay-per-visit because people would pay me for my time, just like a lawyer.
Mm-hmm.
And so shortly thereafter, I had opportunities arise. I had doctors flying to see me as patients from Atlanta. And they would fly up. And then finally, more patients were coming from Atlanta. They fly into Detroit. I have a car pick them up. They bring them to the island. I'd see them for a few hours. They'd go back to the airport. And finally, they said, what's it going to take to get, you to come to Atlanta? And this was how many years ago? A long time ago. And I said, well, the only way I could do this, because I still had two kids still in school at the time, and my son was at college, I thought, I need to have no overhead. So if I fly in, I have to use one of your offices, when I come in. And I'm going to only come every 3 to 4 months, and the rest are going to be phone consults. And phone consults is what I always called it until telehealth, took that term. So you'll hear me still call them phone consults. But, the concept worked so well that we were able to expand and put an office in Nashville. And then I would just travel to see the patients periodically. And it fit the patient's needs because I knew what I do did not require a stethoscope. What I do does not require me to, do this exam every time, which you and I both know does not reveal a lot unless if you're in acute care setting. And so, the idea of consulting really made sense to me. I had a patient in Dubai. Actually, this is a funny story. She's the reason I got the idea. She was came to me when I was originally in practice and she wanted bioidentical hormones. We got her fixed up. Her husband got a job in Dubai, of all places. We were just talking about Dubai. He was the vice president or provost of a university there. And his wife wouldn't move because she said she didn't want to be without her bioidentical hormones. And so he came to the appointment with me and he said, look, I want my wife to go. It's a 3-year assignment. What if we did blood work over there and you do use Skype? I didn't know what Skype was at the time. And he said, that way we'd be able to see what's happening. And so that was really the very first telehealth, was because I was trying to be resourceful for a temporary situation. So it's just pretty interesting how things evolve, but I was glad when COVID hit that only because people now know what you can practice medicine over the phone and on visits.
That's
You can do
true.
it very effectively.
Yeah, I know, and it's actually great, and it's convenient in many ways. Sometimes I do like the face-to-face, the interaction is different, I do miss sometimes it's great, but I think having a hybrid approach is good, and if you can reach more people, that's the best way to do it because, again, we're far from a lot of people, that wanna see us and need to see us.
And I've got a patient, some of these patients, it's been years, of really having that touch point, and I get excited when they do come in. I've got a couple coming in from Kansas. It's been several years, and I'm just so excited to see them in person. So I hear you, but it does afford this ability to. At the time, I've had to do some international travel. I've done phone consults from Russia, Iceland, Europe, it has worked really well to allow me to continue to expand my knowledge base or, be able to still see patients.
And
Yeah.
you don't have to wear and you don't have to wear shoes. You
That's
can be
the best part, isn't it?
extremely comfortable. It's like you see scrubs up top,
I know.
flip-flops on the
It's,
bottom.
you know,
They don't need to know that. As far as you know, as full business professional, your entire visit head to toe. Head to toe. As long as
absolutely.
you know that. So your clinic, Lile Wellness, is fascinating. Or Lile Wellness Partners is the full
Mhm.
name, right? And it's
Full name.
fascinating. Sorry?
No, it is the full name, yeah,
That
but
is
we
the
can
full name.
almost, yeah.
Yeah, Lyle Wellness, right? Because just for the sake of time, if I had to say Lyle Wellness Partners, then that for the rest of this podcast, it's going to go really long, right? But it's really fascinating because you guys, what I like about it, and when I've heard you speak, and I did my, like I told you before I got on, I did my homework, and just coming here, just kind of like, oh shit, I got a podcast today. But you guys are great because it's, you're focused on this proactive preventative care and there's an emphasis on longevity and genomics, right? Which is
Mhm.
super cool because it takes us away from this disease driven medicine to more of this focus on optimizing health and using this. And I remember, man, I was still a student and I hope I don't go in the guy's name of Vedler. They're the ones that did the sequencing of the human genome.
Okay.
And so I remember seeing that. And now this is probably like I was watching some random video on some public broadcasting station. He was talking about it, and I was like, "This is the future of medicine."
Mhm.
Now I'm like a student at the time. I'm like, "This is it."
Mhm.
Imagine being able to know what's going on in your genetics and your DNA, and now it's almost like seeing the future. Like you are programmed for this. Now I'm going to stop this, or I'm going to prevent this, and that
That's right.
is the most amazing thing. And this is probably 10 years ago. And now here we are where we're actually applying it. And
Absolutely.
the most amazing thing. But for a lot of people out here listening, it's like, we learn about DNA in school. There's chromosomes and telomeres and DNA and the A and the G and the C and the T. I'm so glad I didn't say a random letter that was not right. That just shut this interview down.
I'm good. Yeah,
Shut it down. Doesn't know its base pairs. I'm out of here, right? But here's the thing, like, for most of us, we understand that the genetics, mom and dad, and they're fixed. But help us, can you help us understand the difference between that fixed DNA sequence and that modifiable influence of epigenetics, or the difference between the two?
100%. I think the thing that most patients get held up on is they think that your genome is fixed and that therefore I don't want to get my genomic workup because I'm afraid I don't want to hear that I have 6 gene SNPs that could cause Alzheimer's, right? Or I have heart disease. And so what's the point? Well, the point is that our DNA is the blueprint, right? And it's the hardware. It's fixed. Like you said, we have the 4 letters. We won't need repeat them. You did good. But
Good.
we have these little misspellings in there, but they're core to who we are. And it's the misspellings that make us have, some of these issues with our health and, chronic health issues. And so, for example, hardwired in our body and our fixed genome is going to tell us eye color, it's going to tell us blood type, but it also can give us an insight to your baseline chronic, conditions that you have risk for. So I'd like to think of your genome as, being the hardware, but your epigenetics, which, epi, the word means around. It's what surrounds, it's the layer that surrounds. And the coolest thing is that we have influence over our genome. And so, think of things like lifestyle, diet, exercise, sleep, and even mindset can have a huge impact over that. I often would say to patients, they would come in and say, "Why did you come in the office today?" And they'd say, "Oh, my sister has breast cancer. I'm fearful I'm going to have breast cancer." Just thinking thoughts can affect your genome. So it became really interesting when you all of a sudden had this ability to override the genetic expression of disease. And so I would like to think of things as your um, software. Your epigenetics are software. Look, we all get software updates, right? I personally hate it when my phone goes through a software update. It's painful, but when you do it and you have things that now it works more efficiently, it does things that it couldn't do before. So those software updates I would think of as your epigenetics, where we can override the hardware and make it work better, if that
I
makes
love
sense.
it.
Yeah.
No, I love that. I love that. Mine's a little simpler. I
Good.
always say like
Out here.
your genetics. That's the cards that dealt you. Well, I'm sorry. Let me say it again. The genetics of the card. They're the cards that God dealt you. This is what you got. Here are your cards. Epigenetics is how you play it.
That's right.
And sometimes living a healthy lifestyle, avoiding inflammatory, and that it's like being a good poker player, right? You got cards, and a good poker player, Texas Hold'em player, is going to eat healthy and sleep
Yeah.
and focus on lowering inflammation and all the things we think about living a healthy lifestyle. With a bad poker player is out here just no care, or just living a pro-inflammatory lifestyle, no diet, sleeps horrible, just not taking care of themselves, smoking, exposure to environmental toxins, alcohol is a big one as well, excessive alcohol, and all these different things. That's playing the cards horribly, and that's just how we like to explain it a little bit as well. Now, the one thing I want to ask you too is with that whole genetics and epigenetics. Let's just say you have a brother and a sister, same mom and dad, and sometimes you'll see one sibling has this chronic illness, but the other one doesn't.
Mhm.
Now, can that be explained more with epigenetics, or is that a little bit deeper? Because sometimes they
Well,
can say, well, I'm doing all the right things and I'm still susceptible to this.
Well, what's interesting is we're doing genomic workups on generations, right? So we've
Hmm.
got mom, dad, their kids, and their parents. And you have to realize we inherit one from mom, one from dad, except for a few gene deletions or mitochondrial ones. But in general, you get one from mom and dad, right? So here's the thing: if mom has one of a bad gene, and dad has zero, then you have a lower chance of having that gene, right? But you could be the sibling that inherited that gene because you have a 50-50 chance of getting one from mom, right? So I think we have to really realize that we can take a person's genome, and we've done this before. We have a case where, we often will say, hey, you carry two gene SNPs. That means you don't process T4 to T3 very efficiently. And if your parents are on Synthroid, they may do better on T3 because you need it, they don't have DIO2, this carrier to carry it into the brain, and it gives them a higher risk of cognitive impairment. So we can learn from one person's genome, but two different people, we're all so different. I've run it on my kids, my mom. I it's you've got to understand you've got infinitesimal combinations. And so, for example, if you carry APOE4 and you're one of those and your sibling has none, or if you carry TOMM40, which is a mitochondrial peptide, and you have one of those and your sibling has none, you're going to have different concerns that could be addressed. And you can eat exactly the same way, and you can do exactly the same thing, but the genetic expression of disease could be different because it's not one gene that matters. It's the totality of the combinations. And that's where, I think it ggets really interesting because every single person is different.
No, it really is. And I think sometimes when we think about epigenetics as practitioners, I feel like, when I say we, I'm talking about me. Sometimes it's like I tend to like you hone in on like the negative epigenetic kind of switches, right? It's like, you know, don't be exposed to pollution and pesticides and all this. And it's like, okay, and these other things. But there's also positive epigenetic
Sure.
alterations, right? And so I don't know, what are some of the things that can be more positive for that? Is it basic lifestyle stuff, or is it a little bit more
Well,
complex
there
than that?
is, I mean, obviously we can see Clotho gene, which, it's a really quirky thing with a certain gene variant. If you inherit one, it's a golden lottery ticket in a lot of ways. There's a lot of people trying to increase expression of Clotho. But if you have none or two, it's not as good. So again, we have a lot of things in the genome we see as positives, not negatives. And it's just again that's where these clinical decision support tools can really guide you to point out, hey, this is a benefit SNP. You actually absorb vitamin D better or convert it better, or your risk of having you have ApoE2, and your risk of Alzheimer's is much lower, if you carry one of those. So we oftentimes, and when we present these to patients, we always want to point out good. When you're looking at a patient's genome and we're presenting hotspot, we try and pull out what's really important to focus on. And when we do that, when we first started doing them, we just so focused on negative, like, oh, we have to override this and we have to do that. And then I would watch the face of the patient. It's like by the fourth red, they're like, oh no, another red. And I realized for every 3 or 4 reds, we need to put a green one, meaning good, in there because they can say, oh, that's good. I inherited this gene. Right. So it's important, and it's a valid point because all of us have some bad genes. Some of us have a cesspool of genes, but there's also a lot of good genes in there that always don't get pointed out, and probably would be good to continue when you're doing consults to show those to patients too.
I got some bad genes too. They're skinny, and they're really this is a horrible gene joke, right? It's skinny jeans, and they're way above my ankle. Horrible jeans, horrible jeans. I want to wear those outside.
Do not
Y-
wear this
You
outside.
don't. I will not wear
They'll
those
come back in
outside.
style, I'm sure.
Maybe in Vegas.
Yeah,
In
maybe.
Vegas, you get away with that. But so you said something kind of fascinating about that. It's not just a single gene.
Mhm.
And I think that's the hard part, especially we're gonna get into some of the work with the
Yep,
genetic consultations and some of the data that you get, because it's so easy to say like, "Oh, wait, that's red. This says, oh
right.
my god, I am going to get dementia."
That's right.
And it's just like and it's so hard to and then, especially if you're in that cognition section, "Oh, there's 3 more reds." Now you
Gosh.
got 3,
Yeah.
right?
And then
And
when
that
they start comment,
Mhm.
"Oh, this one causes 100% increased risk of cognitive impair," you start
Yeah, it
going,
gets to
"Whoa, what is happening?" Yeah.
yeah. No, it's terrifying, and so I think what you said is and I do wanna kinda have you kinda dive into that a little bit more, is just understanding that it's not just the one gene. It's the
Correct.
combination, and then you have the protective side of it as well. So, how if you have the person with that one single gene and they're scared about it, how do you kinda dissect that and say, "Hey, you got this one bad one here, we're gonna do these things here, the supplementation." But how do you explain that to your patients about, "Hey, don't freak out about that one thing?"
I think the most important thing is it's not just one gene and really getting that across because I think because ApoE4 has been the Alzheimer gene, I think that we have to, really take a step back and say, wait a minute. And this is where my vantage point shifted. If 35% of people with ApoE4 never have cognitive impairment or late onset Alzheimer's, then 65% do, but what are the 35% doing to make them not have that expression or problem, right? And so the people that tend to have the greatest risk are ones that have other genes that have to do with cognitive impairment. And if you do have an ApoE4 patient and they do carry some of these other concerning genes, the key is being more aggressive. Pointing that out, and I've said this a million times, knowledge plus action is power. We have very actionable overrides for so many of these gene SNPs that we can tailor what we're doing to your genome. And I truly believe it's the knowledge that is the power for as long as you have action, right? So we explain these to them, but also, here's the science and showing them research that, this, for example, ashwagandha, if you carry MME, it's a gene SNP that basically doesn't let your body break down amyloid. The paper shredder is broken. And so, there's a lot of studies showing how well ashwagandha works on that. And so we're negating these issues as they're cumulative. It's a rare occasion to find that person who has all of the Alzheimer risk genes. Usually we can see a lot of benefit. So if a patient has ApoE4 and they carry something called BCHE, that combination can be problematic. And this is interesting. Again, doctor, let's give an example. Your aunt has showing cognitive impairment. She goes into the neurologist. The neurologist says, "Oh, your aunt has early Alzheimer's. I'm going to put her on Aricept." Okay, that's pretty standard of care out there. They don't do gene workup. They don't know if she's ApoE4. They don't know if it's inflammatory neurosnips. That's just standard of care. The problem is if you carry a BCHE, which is a butyrylcholinesterase gene SNP, it basically, that's the enzyme that helps you break down acetylcholine. And particularly in these later stages of Alzheimer, you give Aricept in that situation, it's inhibiting acetylcholinesterase. It's trying to raise acetylcholine. But when you carry this gene, you can't break down acetylcholine, and it actually makes you precipitously worse. It makes you have more cognitive impairment and you get worse very fast. And so now what happens is you go into the doctor for your follow up and they say to you, "Oh, my aunt is so much worse." And do you know what normally is said in that situation the majority of the time? "Oh, I'm so glad we started Aricept. We better go up on the dose. It's a good thing we started that early." So again, once you know where your risks are, you have the ability to start working to fine tune and override, but it is the combination thereof, right? That, for example, TOMM40, another really, really important one to, mitochondrial gene SNP, that's co-inherited 70% of the time with APOE4. So, we do know we'd better be supporting the mitochondria. But in doing so, I truly believe, and I said this in front of 500 practitioners at the Ohio Pharmacists Association about a year ago right now. I gave a cognitive genomics talk, and I truly believe anyone that does do this type of detailed cognitive and brain optimization genomics, if they follow the recommendations by you, Greg, or myself, I truly believe we will not see in our practice cognitive impairment because we can dial it in. We can see if it's vascular dementia versus amyloid versus, other forms. And to me, the power in that is incredible. And I think most patients walk away from a consult not feeling afraid. They feel like relieved because now they know what they need to do. It's not waiting for the other shoe to drop.
No, it's powerful, and it's the future of medicine in many ways. Like I said in the beginning of this, now for practitioners, clinicians listening, even some patients, potential patients that are listening, and you start throwing some terms out.
Yeah, sorry.
You said Tom Ford. Wait, no, Tom Ford.
No,
Right?
no.
Not the shoe, not the shoes, not the
Yeah.
shoes. Right? And APOE and MME, and you start and these. It's kind of like with peptides, right? You start throwing these kind of random,
Right. Yeah.
words out there, and again, for me, just starting this in the last year or so, it's overwhelming, and these terms are not. At some point, I know they said this in medical school. At some point, it was probably buried somewhere in the book, and they didn't ask questions about it on the test. And I was like, forget about it. They didn't give
Yeah.
any quizzes on it, right? What's the challenge for new physicians that want to bring this into their practice and take action on these insights?
I truly think the greatest challenge is time. It's like learning peptides. I agree with you. When I first started learning peptides, it was like, what, BPC, what? There's a lot of codes. I will say being patient with yourself and relying on the clinical report, the more you do, the more you can speak the language. It takes time to learn a new language, and this is a completely new language. I do think there's, tools like we're helping practices to do this more efficiently because we do have to manage our time. Where is it? Should it be with the patient directly? It depends on what your passion is. But most clinicians, without a clinical decision support tool like I use Intellex, without that, game changer. I mean, you are literally taking all this raw data. And, if I see a new SNP, I was just talking about TOMM40, I would have to go in PubMed, research. Maybe you can go in Chat GPT now and put it in and get a lot of good info. But the point is, you're constantly having to learn what to do for that. And, you have so many hours of research behind evidence-based medicine, behind these gene SNPs to say what we need to do to override. And I just think as a clinician, know that you're drinking out of a fire hose to start with, but remember what the first day of medical school felt like, right? Or the first day of pharmacy school felt like. It's overwhelming. I remember when they assigned me that cadaver, go home and learn the upper arm. And, you're like, are you kidding me? Because the terminology is so crazy. But go slow, just do the best you can every day, try and be a lifelong learner. And even if it's just embracing one or two gene SNPs, it will get easier. Just like, you and I throw a lot of terms around. I mean, it's second nature to talk about MTHFR or, come on, this is like part of what we say. Our patients know what MTHFR is. But they don't know what MTRR is. They don't know some of these other SNPs. And you're going to learn as when you get handed that owner's manual for your patient, you too are learning. It's a matter of volume and doing more of them. And the beauty I find is I love to learn every day, and doing genomics, you will never, ever not learn every day,
Oh no.
every single day.
Oh
It's
yeah.
amazing. Yeah.
I've done, I think, I had a patient earlier today. I did it, and I was like, okay. And I did one before. I was like, oh, I've seen this before. And I get this one. I was like, oh, I don't know what this is. And you kind of get into it. And thankfully, these tools are great. And this is a good segue because I think the first thing most of us heard of was 23andMe. I think that was the first. It's like, man, RIP pouring out for 23andMe, man. I think they went belly up the last couple of weeks, right? And so
They
now,
did. Yes.
now they're like, hey, where's my shit?
Where's
Where's my
the data?
data? Like, it's like,
Always said that. I'm like, this is going to end poorly. It may not be this year, but it's coming. I had a
I
feeling.
know. Oh, I know. But there's tools out there, and I think there's like a 3x4 is another one.
Let's
There's
see.
quite a few tools out there. What sets the IntellxDNA, the one that you use a lot, what separates that from those consumer genetic tests and some of those other commercial tests that are out there in terms of the data you get and how you can apply it?
To me, it's clinician driven for clinicians. And so, one of the things I love, and you may or may not know that Intellex has two X's in it. And it has two X's because it was two women that founded it, and Carol Bilch and Dr. Sharon. And what I've been most impressed is, Dr. Sharon's background was working with Dale Bredesen, who was like the guru of, memory and cognitive impairment. And they actually are using their tool, Intellex, with their cognitive genomics program. And to me, it's the volume, which can be overwhelming because you are getting, up to 1,200 SNPs, depending on which panel you're ordering, that they're looking through. But it's also the dedication to the research. They put thousands of hours behind these gene SNPs. And so it's not just, oh, let's Google and look at AI. They're actually vetting it. They're looking at peer-reviewed data. They're, really putting into it the energy that you and it would take us forever to put all that together. Yeah. Yeah, and I think all the others are valid. I just think I think 3x4 is a really interesting tool if you're looking at a simpler process. It's much less numbers that it's covering. So, again, if you're looking, I'm not sure if it's 30 or 50 or how many, but I know it's a very small amount. It might be 100, it might be 300, but bottom line is it's just the complete how many they have. And I also like how they organize it because we're able to have detox and right they just are upgrading it so that it'll get even easier, but detox, inflammatory, micronutrient if you have gene SNPs in this. So again, it makes sense for functional medicine. It just logically we think that way, right?
No, I think it's great because I obviously did the 23andMe, and then I also like I started using some of the other tools out there, and the data was good. It was like, okay, I can see why you have a higher propensity to have high cholesterol or insulin resistance, but not to the detail where I can put it all together and look at the risk that's posed to you and like get a better sense of how to clinically address that. And that
Mm.
was impressive to me. And again, it was overwhelming. That first, because I didn't know the whole hot and it will I didn't know the whole hotspot thing. I mean, the first one I did, I
You
did
did the
mine
whole
first on
thing?
myself. Didn't know. I didn't know. So I get mine back and it's literally 120 pages. And I'm like, and I literally was like, if it was a PDF, if I was paper, I would have thrown it up in the air and just said, you know what? Whatever happens, happens.
Yeah.
Whatever happens, happens. And then my life, right? And so, but yeah, I think that learning how to use that information and distill it down, and even like I said, we'll talk more about what you guys do helping practitioners
Okay.
out. But then just some of the consultations that I've been privy to, it's like, hey, you don't have to explain every single snip.
And don't you think that's hard to not
Yeah,
explain every single SNP? I think
no,
it's
I want
learning to
to.
use it
Yeah.
as a tool
Hmm.
because, you gotta realize patients can only take in, they say you should really only go over 6 to 8 SNPs. I find that most of the patients in our practice are seeking our care because they're
Hmm.
highly knowledgeable, right? So,
Right.
I don't think 6 to 8 makes sense, but I do like to cover the hot spot, but we try and keep it to an hour because it's information overload. And here's the thing,
Hmm.
I refer back to it every time I do a consult. So that cheat sheet we kind of provide doctors, it's invaluable because, you can be sitting across from someone. I just had this happen, uh, not today, it was a Friday. And she's, been a patient for a while and we just did her genomics and she happened to have some ringing in the ears and had been going to doctors quite a bit. And, MTHFR can be associated with that, but it really was seen more significant. She got an MRI and she has amyloid angiopathy. She had vascular, micro hemorrhages, and just it was small enough. But she's also a brilliant woman, and you would never know that there was anything, and she's 65 years old. So she goes to the neurologist, and the neurologist says, and she even commented to me, she's like, I was literally it was scary who was sitting in that neurology office. Because when she goes back, the doctor takes a look at her and he goes, this is natural, normal, healthy aging. Well, no, it's not. It's not normal. We know the why behind it. We pulled up her gene SNPs, and she just recently had done it. I said, this aquaporin 9, game changer. We know what we need to do. We're going to use cerebrolysine in her, something there equivalent. But, the point is, she could compensate. And I always say, if you're sick, you never want to put makeup and brush your hair and look good at the doctor's office, because, really highly articulate people, you go in and he's like, you're the healthiest person I've seen. This isn't a problem. But is it a problem? Yes. If you're going to have longevity and you're going to live, we can't continue to have this progress. So, I think that's where the why behind things, because his explanation was, oh, well, you had mild diabetes for a few years in there, and this is how a third of my patients age. Well, maybe that's because of their genome.
Something
right?
to think about.
Her outcome's going to be a whole lot different. Yeah.
Absolutely. Absolutely. Hey, everyone, quick break to let you know this episode is sponsored by Tides Wellness, a company I co-founded and I also serve as medical director for. So as a naturopathic doctor, I spent years prescribing peptides in my clinic, and I helped formulate every product in the Tides line to make it high quality, effective, and more accessible. No needles, just science-backed ingredients that work. I personally take our products every day. I start my mornings with our Rebuild drink powder, and I usually take a second serving after the gym to help with muscle recovery and electrolyte replenishment. Now, when I want to unwind, I reach for our de-stress gummies. They help me relax while staying clear and focused any time of the day. And last but not least, to keep gut inflammation in check, our Revive gummies are my go-to. I use them consistently, and I recommend them to my patients all the time. So if you're curious to try them, you can get a 15% discount off your first order at yourtides.com with the code Dr. Jones. That's DRJONES. Again, you can get a 15% discount off your first order at yourtides.com with the code Dr. Jones, DRJONES. So Tides is about making cutting edge wellness simple, effective, and part of your everyday routine with the power of peptides. This is all pretty fascinating here. Are there any special cases or any things that it's like, if you're talking genomics in your practice, here's that guy, that gal that I want to tell you about, where you saw this data and this information impact their life, change their life, and just make that world of difference?
I've seen many cases. I think to me, there's two ways to look at it. I have, patients that are sick, and I have patients that are in preventative care. Sometimes seeing and I've mentioned this before when I talks, it took taking care of cancer patients and looking at their genome to see the why behind it that made me understand how important every one of those gene SNPs are. So, for example, a lung cancer case, and I've had several cases of cancer where this has happened, and so I'll keep it a little bit more generic. But, particularly, a young person with lung cancer with mets to the brain, and we did the case not for looking, because this is not a cancer tool. This is looking at chronic health issues. So I was doing it more for her mental wellness. She had chronic history of depression, and, we were trying to help her to deal with what she was going through. But what was incredible, when I started opening her gene SNPs, it was one after the other in there that she had one of the worst detox pathways I've ever seen. Every single gene SNP. And it would come back and it would say, and you can see this in the provider section, 200% increased risk of lung cancer, 150% increased risk of cancer, and you start seeing that over and over again. You start realizing how important our detoxing is, because I think you and we say it all day long, but to actually see that live, what caused this person, I truly believe we got to the why behind her lung cancer. And in doing so, she's doing so well, because we then saw she carried the aquaporin 9. We saw that she's got these channels that are carrying all this bad stuff into her brain and causing neuroinflammation. We're able to help prevent future brain swelling from her gamma knife and other issues. So I just feel that in her, it was such a powerful case to me, because it empowered her to know, look, I'm doing everything I can to not get a recurrence. I have a small son who I now know what he has risk factors for. I don't have to live in fear of this any longer. And so again, these gene SNPs, every time you do one of these, you're going to learn. And, but it's the cases with chronic illness. I had a patient with Parkinson's, pretty significant case. It was in 2020 because I remember coming in person. It was kind of a big deal that he was coming in person. And when we did his workup, he was on, high dose Cinemet and other medications and not well. But there was something about his case when I was looking at him, I really had to work hard to convince him to do the genomics. He had been to a gazillion doctors at that point, and just trying to optimize his health as best as he could. And he'd heard detox and he'd heard, about these types of things. But finally, after about 9 months, I said, I know I can help you, but I have to see what's going on. I need to see the owner's manual. It's time. So he finally relented and agreed to do it. And when we uncovered so many neurologic pathways, GABAs and glutamate and all of these things, change everything up that he's doing based off his genome. And fast forward 3 months later, I do a telehealth call with him. And I'm like, where are you? And he's like, oh, I'm in the Carolinas. He was in a hotel room. I said, in the Carolinas, what are you doing? He goes, I'm hiking. I go, you're hiking? He goes, oh, guess what, Dr. Lyle? I don't have Parkinson's. Well, I'd already said that to my team as soon as I met him. I'm like, something's off here. But after I saw his genome, I said, I really don't think he has Parkinson's. His neurologist said, hey, you're so much better. We really don't think you have Parkinson's. And he was weaned off and he's living a normal life to this day. So, I mean, these are powerful tools. These are the sick patients. I think they're the most impactful because you're like, we can change the trajectory of this. But these preventative cases, again, I just had a case in Florida. He was told by cardiologist, he's new to me, just last 3 months, 4 months. I take care of his brother and his mother. And he's like, look, I go to a cardiologist. He has never had a cholesterol above 135. He has had his LDL completely normal. He still goes in for a yearly physical because he carried a little bit of extra weight. He was a big guy. He was an athlete that got a little bit bigger. And what's incredible is, the cardiologist said, look, you will never have to worry about your heart. And he'd get his EKG and he'd get all these tests. Well, we did his genome, and that man had, TNF alpha, he had clotting factors, he had cardiovascular risk factors. And when you look and see all of those together, I finally just said, look, I know your cardiologist said that this will never be an issue. And I agree, your cholesterol looks excellent, but I feel like we need to do a CTA and a clearly because of knowing your brother and your mother. Do you know he had 100% blockage of his RCA, 100% blockage, and 61% of the LAD? You can imagine that conversation with the cardiologist. But, the point is, we can't know. We can only go. And the blood work gets us really far, but it can't tell us the whole story. And I would have never checked his clearly. Even with a yearly appointment at a cardiologist, he's never going to get checked. And it was only because of his genome. He was getting ready to go out of state and hike himself, and could have ended disastrously, in Colorado.
Oh my gosh, that would have been amazing. And it's easy to see that. And now that you're saying that, I think there's a lot of patients that I've said, hey, look at your amazing cholesterol, you're good. But I think and again, the good thing about this test, like the IntellxDNA, it's an investment, but it's a one-time investment. This
right.
ain't changing.
No.
But at least you know, and you know what to look out for. But this leads me to a question since we started talking a little while ago about some of the people you've seen and some of the data you get. And this is a challenge we have, especially, I think, in medicine, even naturopathic medicine, because we're a little bit more supplement-based, is that it's so easy to give someone something. It's so easy to start someone on something. Sometimes it's really hard to take them off. Or get the question, how long do I need to take this? Can I ever stop this? That's a hard question because sometimes I don't know the answer day one. Sometimes it may be a matter when your labs are better. But when it comes to the genomic testing, let's just say you have that that NLRP. Did I say that right? That's the
Yeah, very
inflammasome
good.
one?
Yep.
That's right.
No,
I'm learning,
yes.
right? And you have that CXCL, and it's just like you need sulforaphane and you need turmeric, you need these supplements, the supplements that can help you. Is this because it's genetic and you're addressing a genomic issue, is this a supplement for life now?
I love this question. I really, really love this question. I think you would have made a great pharmacist.
Oh, thank you.
But that is such a great question. So I always tell patients for now, but I rotate people on and off of supplements. So we'll actually take it a step further. You do not need sulforaphane every day of your life. So we may rotate it into the mix 4 months, out of the mix 4 months. So we're trying to touch point a lot of these genes, by using the right supplements in a rotation. Because if you take something continuous all the time, you run this risk of receptor saturation. You're not going to get as much impact from it. And, just like with peptides, signaling, starting and stopping is good, right? What I learned in our practice years ago, I track compliance because we fill the scripts the majority of the time. And I can see, and as a pharmacist, I can see, wait, that they're out, they should have run out a month ago. But early on in my practice, I would rotate people on and off, or I'd have them take it off a week, every 6 to 8 weeks, don't take supplements for a week. That was a great in theory, but what I realized is that people naturally miss days. When we try, and it's almost intuitive that I don't think they do it intentionally, but we see, oh, they have 20 morning packets left and they have none of the evening. Obviously, they've missed 20 packets. So we actually stopped that concept in our practice because people are naturally going to miss. And if you are already cutting out a week here and there, they're going to not have enough, right? So it's that fine, delicate balance. But I think it's a great question. And I would also say to patients, look, what we're doing now, we're going to look back and these are going to be barbaric times. We are going to be, can you believe we drew blood? Can you believe we stuck needles in people? I truly believe that, the whole goal right now is keeping your body optimized because those that are in good health are going to be able to enjoy the insane things that we are learning in medicine. And it is happening very quickly. And I do think we'll look back and say, I could see something where you sweat, you put some sweat on something or you spit and, all of a sudden it calculates what you need for the day. You click it into a 3D printer. That 3D printer can make any kind of bread you want. You click, oh, I'll have sourdough tonight. It mixes all the supplements and all the things you need and it rolls it out and you cook your little piece of bread that has all your supplements in it. That would be fun. It would be interesting, but it's what we're doing now, we won't be doing
Oh goodness.
by
I think
10 years.
about where we were 10 years ago. Like even when I started med school, it was like none, half the stuff. But the
Yeah,
way AI is going, man, I feel like
it's
there
insane.
that is a big and the whole other podcast on that is like, how do we, because right now it's like you cannot run from it, even if you try to. And if you want to take it old school and not use it, God bless you, because it's
It's
gonna be nah,
you have to use it.
you have to. And
I
because
used it the other day on a patient, interestingly enough. I knew he was a chat GPTer and he had sent an email. Oh, I put in and it's saying that there's some of the redundancies in here. This is kind of a funny story. I'm not recommending it to practitioners out there to use this as a training tool, but it got really interesting because he wasn't being grumpy about it. He's a great patient, but he's just like, look, I'm just curious. I'm using this for my education. And, it's saying that I only need this many supplements. So we get on the consult and I said, what? And, I'll make up a name, Peter. But, I'm like, Peter, why don't you put in there that you carry PPAR and, you have 2 gene SNPs of that and ask it if it changes the answer. And then it comes back, absolutely. And it adds in the actose or some other things that we had in there, right? I said, okay, we're going to take it one step further. Now I want you to put in that you're an APOE 2/4 and you have TNF alpha. So, and then he's doing it on the screen. We're together. We're on a Zoom. So he pulls, I'm watching this, right? I'm like, please, dear Lord, let ChatGPT agree with me. So he puts it in, I said, and ask it, what supplements would you change? Would you change your original recommendation? Do you know it came back and it said that changes everything. You are completely optimized with your previous regimen and just went on and on about what a brilliant mixture. And I'm just laughing. I'm like, thank you for agreeing with me. But, listen, this is where we're at. And you and I've had really smart patients come to our practice because they're focusing on, preventative health and longevity. They've always been the well-read patients, but it's those that it's knowing what prompts to put in. And it was a great experience. I mean, he walked away being so happy and thankful because he's in the investment world. And he's like, I use this tool all the time, but I always tell my clients it's not going to replace, you can never use this and replace what I do because it's how you prompt and how smart you are with it. And that's where our wisdom comes in.
It is. And it cannot, to me, it cannot replace empathy. It cannot replace intuition. It cannot replace that relationship you have with the patient. It can't do that. But what it can do, if you say something to me like, I'm going to say this, TOMM40, right? If you say to me, right, instead of me having to go to PubMed and look at 20 different articles, what am I going to do this? Do I get the right thing? And granted, I appreciate, it's kind of like going to the library as a kid. I appreciate the struggles I went through because it makes me really just really be humbled by the things we have now. But the fact of the matter is that we've got better sourcing now. I can go to Google LM or I can go to Open Evidence and say, can you teach me about TOMM40 and get evidence-based research articles and actually learn this faster than if I didn't have it. To me, it's a tool to learn faster. Like I can't read 1,000 research papers, but that thing can read 1,000 research papers in 30 seconds.
That's exactly right. That's how I think. And it's also, I always say minutes matter. And every minute that you save in a day, it can affect how much more you can learn. It's all
exactly
how it's being presented to you.
Exactly. And I want this to be out there on the internet. So when it becomes self-aware and realizes that humans are horrible and decides to take us out, remember Dr. Jones and Laura Lile, they said nice things. Said nice things.
You're my friend.
We'll keep you. And all this stuff, and just change our transistors out when we need it. Right. So good segue into one of my last questions for you here is what excites you the most about where this genomic-driven kind of precision healthcare is going in the next 5 to 10 years?
I think that what the most exciting piece is that we are going to have more access. We had it wasn't that long ago, the human genomic sequencing, the whole DNA was processed. It was really literally in 2003. So think about it, Greg. It's 20 years later, 22 years later. So what the heck? I mean, now with AI, we're going to be able to now have it at our fingertips information like you just said. And so I think we'll be able to plop these kind of things into learning tools. It's going to be able to make the work that Intellex is doing go exponentially faster. Because remember, all of that requires hours and hours of human research. So if you have these AI tools that can now process thousands of articles to give us the down low of what the evidence shows, I just think these tools are going to get larger and more comprehensive, and we're going to continue to learn every day. And I also think that they'll get more cost effective. I think, 5 years from now, I really believe that, my hope is that this becomes a platform that's standard of care in preventative health in our types of practice. Should be standard. Just like it's standard to balance your hormones, it should be standard to have your genome done.
Oh, absolutely. I think we'll get there. I think once the evidence gets there, the research gets there, people see it just takes enough of that groundswell. People say, this is something we want to do. And I've always felt this thing about preventative care. And sometimes, a lot of our patients, their insurance network will fight it. Like, oh, this is preventative. We're not covering this. It's like, don't you want to prevent the thing
it's going to cost you hundreds of millions of dollars,
Whole other story. That's a whole other podcast right there. So and this is one of my favorite questions to ask my guests. If you could go back in time, and let's just say at the start of the journey, right? You're like sitting there, like, you know what? I see that Drive-Thru. I'm going to put that pharmacy. We're there, right? You're at that moment when you had that spark. What is the one thing you would tell yourself? You can go back and say, hey, I'm here. I come from the future. Grab yourself by the shoulders. You need to listen to this. What would be the thing you tell yourself?
I would say, first of all, don't blink because time is going super fast. But beyond that, I would tell myself to continue to always trust your intuition. And just because you're doing something that the other people aren't doing, that doesn't mean you're not on the right path. That is truly, in my career, it's every juncture that I have stepped through a doorway when others hadn't yet. When there were 50 compounding pharmacists, you were an anomaly. Drive-Thru, anomaly. Concierge medicine, anomaly. Genomics into medical practice. Everything I've stepped into, I've had to understand and realize that innovation can feel like resistance, right? You get resistance when you're innovating, and and you're going to be lonely at times because you're a lone wolf out there. But the reality is, when your intuition and your innovation is aligned with your purpose, you're no longer pushing like boundaries. You are literally setting new standards of care. And so hang in there. It's going to be lonely at times, but the rest of the world will catch up with your ideas.
That is amazing. That is amazing. So I would say last one, we're going to make this a two-parter here. For patients who want to learn more about this proactive kind of genomic-driven, genomics-informed care, where can they learn more about your clinic and yourself?
So they can go to our website, LileWellness.com. We took the partners out, so it wasn't so long. LileWellness.com, Lile, wellness.com. The practitioners can go to Lile Wellness and then /LileGenomics.com. It's just another place that we've got just for practitioners, or they can email us at our office, and contact us is right on there. I think those are the best ways to reach out. And then we have, patient coordinators that can help. We do genomic only consults for many patients that maybe are just trying to get their owner's manual to get their doctors to see it. So just like you're incorporating this into your practice, there's patients out there that can reach out directly, and because they can't get this tool, it's through clinicians.
Good. Well, you just answered both questions, because I was going to ask you, where can patients learn more, where can us doctors learn more, and you nailed it, knocked it out of the park.
If you email me at Dr. Laura, Laura at Lile Wellness, I will definitely get back to you. And we're here to help. We want to grow and to make this standard of care.
All right. Thank you so much. Well, this has been amazing. And I want to say thank you for your time. I truly appreciate it, because I know you're 3 hours ahead right now, a busy day, running 3 practices now, doing all the things, traveling. I think you're going London. Where are you going?
Heading to London. Yeah, speaking over there. Never a dull moment. It's all good. Though. That's the beauty. When you love what you do, every day's a journey. That's for sure. Just love your work you're doing, Greg. So keep up the great work you're doing.
Thank you. I truly appreciate it. And this will, you're not getting rid of me yet. You will be back on this podcast. So just hopefully be ready. Let's do it again. Let's do it again.
I look forward to it, Greg. You take care.
Thank you so much. All right, everyone. This is Dr. Jones in the Optimization Academy. I want to thank you all for listening. There will be information on Lile Wellness and the work that Dr. Lile is doing in the show notes. Until next time, everyone, let's stay optimized.